Johan, for letting me kind of just speak today, really. The first thing I was going to say is that I'm not the expert. I think with breaking bad news and talking to cancer patients, kind of we live and learn. We learn through our experiences. We've all had experiences when we've given information to patients and it probably hasn't gone as well as we would have hoped it to be. But when I was thinking about kind of what I was going to speak about this morning, I was thinking about kind of my experiences and kind of how I think things, what works well, what hasn't worked well, and kind of some of the bits that we're kind of as nurses told about breaking bad news. Okay, so. Some of the evidence about breaking bad news is it kind of goes on, for the majority of patients is that they may or may not have a relationship with that person, that doctor, that nurse. But we know, don't we, that likely when we're seeing patients in clinic, it is the first time that we're having any contact with that individual patient. So we don't really have much of a rapport. We haven't got a kind of ongoing relationship with that patient. So when I think about breaking bad news or speaking to people about cancer, I think about the first kind of 4 kind of basic steps, and you guys will be the experts because you've obviously done this for quite a while and not just with cancer patients, with lots of different situations. I find it importantly, right at the beginning is kind of the introduction and setting the scene. Now, this obviously a lot of the consultations that we're doing are on the telephone, so it's going to be completely different from when obviously we do it face-to-face in clinic. I think the face-to-face clinic appointments are helpful because what I learned over my 18 years, it's kind of not just what the patient says or doesn't say. It's kind of the verbal, the body language, it's the non-verbal. The behaviour, do they look like they're going to faint? Someone really angry, those kind of things. That can be really helpful, kind of the way that we support and the information, the way that we deliver that information. So I put in introducing or setting the scene. Obviously, some of the feedback I've had locally, recently, was just about some doctors, how that they behave in the clinic room. Do they get up when a patient walks into the room? Do they greet the patient? And patients, I think, and generally find that quite helpful. Appreciate social distancing and kind of elbows and things like that. It obviously is a little bit different, but introducing yourself and setting the scene is really helpful. For me, it's kind of we have read, before the patient comes into the room, we've read the notes. We know what has been told to the patient or the information that we've been given about what we believe the patient understands, but that generally isn't what we're faced with, is it, when we see patients kind of in the clinic setting. So set the scene, introduce yourselves, and introduce other people in the room. If I'm in the room, on a few occasions I've been introduced as the cancer nurse, either prior to the patient even been told they've got cancer. So I think it's just being aware of kind of who's in the room and, regarding that, just making people aware, because people are really anxious when they're coming in at the best of times for any information, especially if there's a query that there could be something malignant going on. So introduce yourself. What does the patient know and what is the patient expecting? And I find this really helpful because, you can read a letter that says this patient has been informed that she has a pelvic mass and it's very likely malignant and we're looking at operation. When the patient comes in, they say, actually, I've not been told anything. And from the majority of patients, especially if they've been referred in on a 2-week cancer wait, a lot of patients actually don't know what that means. So they think, oh, I've been seen very quickly at the hospital, but actually they don't really appreciate it's because we think there's a cancer. So, that stems right back. And there's been a lot of work over the last few years about the information that the GPs give to patients about the referral process and the concerns about why they're referring patients in on this kind of 2-week pathway. So what does the patient know? What does the patient expect? I always think about explaining reasons for the consultation. I kind of like can I ask you, what is your understanding of why we've made this appointment for you today? What are you expecting from today's appointment? You can see as well as hear from what the patient says that they had no idea what they were brought in for, or that they were really anxious and they know that they're coming for some results. So I think the introduction is the most important thing, because as we all know, with any consultation, whether it's breaking bad news or not breaking bad news, is if it doesn't start well, and people are not relaxed and people aren't listening or engaged, and we've lost them at the beginning, then we're not going to get very far on that consultation. So a good introduction and setting the scene, and kind of then moving on into delivering the facts, really. So being concise, sticking to what we know. We're all really good. I am one of the people that do this, and is sometimes we feel that we give a little bit of information and we feel like we have to kind of carry on talking to try to explain further when the patients look a little bit lost, or aren't really up to speed where we are. So be concise, stick to the facts. It's okay to say that you don't know the answers to certain things, and I find that really helpful. And in some respect, I think patients respect that more than rather than just saying, oh yeah, no, I think this is what's going to happen, because they need to feel safe, don't they? They trusting, and as I said, if we then, that isn't the case of information we've given, then obviously they do lose trust in us. Pausing, recapping and giving time, as we all know, is that we can deliver this information. Then ideally we should stop and just kind of take a breath and kind of see whether we've got any questions from that. Does that make sense what I've said? Generally you can tell, I think, majority of the time, about if that person's understood what you've said or hasn't understand, and sometimes it may be the use of jargon that we use, and I think that goes on with what we do generally, don't we, when we read people, and we know our audience, because recently, I've come in contact with the patient, and the patient's son is a consultant, obviously, and we've had patients that are healthcare professionals or different professionals, so maybe their understanding is very different, and how we would deliver that consultation would be different for somebody that has a different job. So it's knowing your audience, recap, giving time, looking for non-verbal or verbal cues. When we've had, obviously, some patients are really, really shocked when we see them in clinic. I always reiterate and always reassure people it's okay to cry, those kind of things. I think sometimes we feel it a little bit awkward because we're not really sure, especially now, because we're not supposed to kind of support them or physically hold their hand or support them physically, but it is okay to be upset. These are life-changing experiences. For majority of people that we're having these conversations with, their life will be cut very short. They're not going to survive this, and it not only impacts on that patient, it impacts on everyone. It just impacts on that patient, the person in the room, maybe partner, son or daughter, grandchild, whoever's come with them on that day, but also it has wider implications for the rest of their family. So I feel quite comfortable with people getting upset, because actually, in some respect, I think they've actually understood what we've said. Watching for non-verbal cues. Obviously, there's some concerns where you get people getting quite aggressive and angry, especially if they feel that there's been difficulties or challenges kind of prior to their diagnosis, really. So delivering the facts. I think once you've delivered the facts and you've kind of maybe recapped and given time to just ask questions, and it's okay. And I say it's always okay to ask anything. It doesn't matter if we've covered it, because maybe I haven't explained it very well, or we're more than happy to go over anything that we've discussed today. That is important then to think about the onward step, really, isn't it? Onward, what do we do after that? So I kind of think that once we've delivered the facts and we've kind of answered the questions as much as we need to, and it looks like the patient's ready to move on, then we can talk about onward planning and concluding. Again, that's recapping, isn't it? But I think we're, as nurses, taught, when we talk about advanced communication and breaking bad news and the situation in cancer care, one of the things that kicks in is try to end on a positive note if you can. Well, that's not always easy, and it depends what you mean by positive. For me, that can be we've told you about what's going on in your results. Now what we need to do is we're going to refer you on to the oncologist, we're going to refer you to a different centre, we're actually going to speak to our symptom management colleagues in the community, and we're going to put a referral in to see whether we can improve upon your symptoms. So it's kind of bringing everything together, onward planning, thinking about what we can do going forward. Importantly, contact details. So for majority of patients, obviously, kind of at the Royal Berks, well, everybody in theory with the diagnosis of gynae cancer should be given my details. And obviously in the other unit centres, they have their own CNSs. Give details, contact details, because what we've got to remember is that the majority of what's been discussed will not be remembered, but it's important that the patient knows it doesn't matter if they forget half of the things that we've talked about today. They know who to contact after the consultation to kind of pick up upon those things, or to have further information or clarification. So that's really important. So onward planning, concluding, a lot of recapping, and I know that during the consultations, a lot of the consultations that I'm part of, it's a lot of reiterating the same thing over and over again, to the point where you think the patient's had enough, or it looks like they've actually got what you've said, that kind of thing, really. And loads of opportunities to ask questions, and that's important. And I think also, I mean, more so currently, I think we are still trying to have, especially if we know that we're breaking bad news, asking, it's difficult to say you can bring somebody with you, because then people will expect that you're going to give them bad news. But obviously, if somebody comes in, we're allowing them to come into the consultation as much as we possibly can do, because we completely appreciate that they need their support as well. But asking permission, is that okay if I can ask your husband, do you have any questions for us? Again, reiterating contact going forward, and like leaving it, going forward. I think that's kind of where I think we are with breaking bad news. I mean, hand on heart, we've all done it not so well, and we've all had consultation. We think, "Cool, that was brilliant. I'm really pleased with that. I'm gonna use that. That's going to be my standard going forward." I mean, some of my examples, I was thinking about kind of where I think things haven't gone well is, I think I mentioned on a couple of occasions when I've been in with a new doctor, they said, they introduced themselves, we're here to talk about this, and this is Lisa and she's the cancer nurse. Well, that's not very helpful if we haven't actually told the patient that she's got a cancer diagnosis, and of course that causes a lot of distress and alarm, and then I don't think the patient actually listens to anything else which has been said. We've had patients that on some consultations, the use of wording. So it's important to say cancer. It's important not to say nasty cells or bad cells, because we had a lady that had a hysterectomy, and it was an incidental pickup, not for suspected malignancy. And she was told that she had some nasty cells. And if she did any further treatment, she had some nasty cells. And then so I go in and introduce myself, and she says, "Oh, that's good news, isn't it, that it wasn't cancer?" So I think being very mindful of the terminology that we use, good or bad, kind of thing, and being very clear with patients. I mean, I was going to say a little bit about the MDT. Obviously, MDT and breaking bad news. What I find really helpful, so obviously I can only speak for myself, is that as the only gynae cancer CNS at the Royal Berks, is that when patients are added to MDT and they've come through clinic and they've had some investigations, or they may have been on the ward, and there's been interaction, there's been concerns that this could be a malignancy, is obviously it's great, which generally happens anyway, and generally happens by the junior doctors rather than the consultants, is to just comment or document what the patient knows. And I know that sounds really basic, and it generally does happen, but that's so helpful for me, because actually I know because from MDT, it's generally myself that would have to cold call that patient after MDT with an update, or to invite them to come up to a clinic, or say that we're referring you to a different speciality or to a different hospital. So yeah, any information like that would be really helpful. And contact details, if that person is elderly or has hard of hearing or has a learning difficulty, or if there is a reason why we shouldn't be contacting that person, and then who we should be contacting will be great. But that generally does happen. But it's just to reiterate, I find that really helpful, because there have been many occasions from MDT where the letter or the discharge letter will say this patient is aware of CT findings or suspected malignancy. Then I phone the patient, and then the patient isn't aware of what's going on. Again, not everybody reads their discharge letter when they take them home. Some people read it religiously, a lot of people don't. So I'm not sure if that how that sounds, kind of. I'm just thinking, looking through my notes about that, really. We're all good at, communication in general is one of our hopefully strong points. Good eye contact, kind of, I think, room positioning, kind of know your room, and things like that, really. I mean, it has been a bit more of a challenge because we're doing a lot more consultations over the telephone, but I think that in some respects has some benefits. But obviously, I'm aware that when I'm speaking to patients over the telephone, it's difficult because in clinic you're responsible for them. You can support them afterwards. If you were concerned about them, then you would obviously stay with them and spend more time with them. Obviously, when they're at home, you don't know if they're on their own. You don't know what their situation is, and then you obviously leave them kind of at home on their own or whatever, really. But in some respects, some people do prefer telephone consultation, and I think it's up to the individual consultants about that. Some consultants prefer telephone consultations, and some consultants will prefer face to face. I think everything we do is with kind of breaking bad news or initial consultations with patients, even if we're working up to, we think this could be a cancer. I think being very honest and upfront is brilliant, because it sets the scene, doesn't it? That it makes the next person's job a little bit easier if that patient has an idea and is clearly written kind of in the doctor's letters or in the notes or things like that, really. How does that sound?
That's brilliant. Thank you so much,
Sorry.
Lisa. That's great. Yeah. Any comments from anyone?
Thank you. That was really useful. I think, what you said about knowing what the patient knows is really useful when people can document on EPR or literally anything. Patient is aware of diagnosis, or just, patient's not aware of diagnosis, anything really.
Right. Yeah, no, I agree. Yeah, absolutely. Thank you.
Or even if it's a suspected diagnosis, because I know when I see someone in outpatient hysteroscopy, for example, I can see something and it might look suspicious. And I think it's only fair. I mean, it's getting the right balance, isn't it? You don't want to obviously petrify them and think, oh gosh, and they'll be worrying for the next 2 weeks until they hear back from you. But also, you never falsely reassure these patients. Yes. I mean, I had someone a couple of weeks ago, and the daughter-in-law was translating for the mother-in-law, and there was something that looked nasty, and she said, oh no, we don't want her to know. Can we just wait for the results and see? But that didn't quite sit right with me. So whether or not she understood or told her, it's difficult. And ideally we would have had a proper interpreter, but I said it's important for her to know at least that it's suspicious and that it could be cancer.
Yes. Yeah, absolutely. I agree. Yeah, exactly. There is a fine line, isn't there, about worrying people unnecessarily, but it surprises me, I guess, because I'm only looking after people that have a diagnosis of cancer or suspected cancer, that when and it's talking back right from the beginning of referral in via the GPs for not emergency admissions, but people coming in via GP on a 2-week wait, not actually appreciating why they have thing. I work obviously closely with Mrs. Jane and she's very good at saying you've been referred under a 2-week wait, to kind of just establish what has been said at the beginning, isn't it? Because you are picking up from the person that had seen that patient before you, aren't you?
Absolutely. And I think, I know there's a lot of emphasis with all this breaking bad news, giving them a warning shot. It's not good news. But I think, as you say, Lisa, establishing what do they know first is probably even better, isn't it? Because then you can use their language, use their cues. That's helpful. Lydia, you've got your hand up.
Yes, thank you. I've not been to many gynae oncology clinics, but I've almost struck sometimes when you break bad news, a lot of the patients that I've seen that want to know why, and it's very difficult. I mean, you maybe just found, well, not me, but you haven't done any of you've only just found out the diagnosis. We haven't really got any more information than then. And how do you, I know you said it's fine to say I don't know, but I found a lot more than we knew at that point.
Yes. Yeah, that's a good point. I mean, so in Reading, our MDT is a Monday afternoon, so we have specific kind of protected MDT slots with Miss Vijay and on a Tuesday and a Friday. So we would allocate one of those clinic slots after MDT, so that we hopefully don't run into that. Occasionally, as we do, people were coming to a clinic and the results are available, and then we'll And again, I suppose in that instance, could you, I know kind of, I'm just thinking back, we would probably say, or if I wasn't at that consultation because we weren't expecting that patient to get that result on the day, hadn't yet been to MDT, how about saying something like, you're on MDT, no, we're going to be discussing you officially at our MDT meeting and explain a little bit about what that means, and we're going to kind of confirm a plan and what's needed, and we're going to, I don't know, it depends, we're getting another appointment next week, or whether the CNS contacts. I mean, how would that work? How does that work? Or would that kind of work? Or do you think, Lydia, do you think that something like that? Because yeah,
I think that does work. That would always be my default, mainly because I would just ask the consultant as well. But yes. I guess it's that balance in that they obviously, we just started something big, and there's a process that we know that we're going to do, but this is all new for them, and a lot of the questions will have an answer, but it's just I think it's maybe it's to do with your tone of voice. You're not putting them off, it's about being reassuring rather than dismissive. But because it is about because there was one patient who was frustrated because she is like, well, why have you told me if you don't know anything about it? So yeah.
Yeah, I agree. And actually, it made me think that there was a lady that came in that was going to have a diagnosis of an early endometrial cancer. She was on the MDT on the Monday, but came in the week before bleeding and was seen in kind of an emergency situation. And the results were available. And so a senior doctor spoke to her because she was asking about the reason for the bleeding. So he's very honest and very well written and well documented. But then she complained because he couldn't answer all her questions, and she felt that actually it shouldn't have been delivered. But then she asked the question again. So it's really difficult, isn't it? Because I think, sometimes you can't do right from doing right, can you? And if you hadn't given that information and then you say, well, didn't you have that information last week? So yeah, it is really hard. I mean, I can remember time, you think of times, don't you? Because I think you don't always remember the many consultations that have gone really well. You only think about the ones, don't you? Think, oh dear, I don't want to do that again. When sometimes you get yourself in a little bit of a hole, you're backed in a corner, things like that, really. And you feel really uncomfortable because I think we all want to fix, we all want to leave that patient with a clear plan, and the trust that they trust in us, that we know exactly what we're doing. But I know I would just go back to sometimes it doesn't sit well with us to say, I'm really sorry, I don't know, but this is how we're going to sort this for you. But I don't think there's a right or wrong. I mean, I'd like to think that was probably maybe a minority. Is that a minority rather than majority? I've kind of seen patients, isn't it? Sorry.
Yes, it is.
Yeah,
I think you're right, Lisa, because you don't want to give anyone a false sense of hope, because I think that does no favors for anyone. And actually, I think sometimes the best thing is just to say, I don't know.
Yeah.
And that's with anything in medicine, isn't it?
Yes.
Like you say, you want to make people feel better, give them an answer, but actually you can dig yourself into a hole quite quickly.
Definitely. Definitely. And all I was going to say is, and none of us are experts, and we all and there are times, and we all say things meant in the best way, isn't it? Really, that don't come across as in the best way. And we all learn from that, but we shouldn't beat ourselves up about it. I think we're doing the best we possibly can do. We can reflect upon it and hopefully learn from it, but kind of thing. So I think if you have like a negative consultation and actually you don't know how you've even got into that situation, I think it can really knock your confidence. And at the end of the day, I think in oncology, when we've got new patients in oncology and maybe they've been a bit challenging, and the doctors may say, I feel that this patient's been maybe a little bit challenging, it's been a very difficult situation, and we've got new doctors and they maybe don't feel so confident. And I always say, do you know what, at the end of the day, you know what you know, and it is okay not to know stuff, but actually just as long as you go in and you're confident, isn't it? I mean, I don't mean that's bluffing, but it's important to, even if you maybe in the inside don't feel as confident as you wish you could be, you still need to be confident, because that's what they're picking up on, isn't it?
Yes, absolutely.
Yeah.
Out of curiosity, Lisa, what's the most commonest reaction?
And do you know what? I think that I'd like to say majority of cases, because we've prepared, because royal we, not me, prepared people, that they are kind of coming in and they're kind of expecting it, especially as we were, you know, if they've had an appointment come through within a week, you know, those kind of things. So they're kind of expecting it. I mean, I've had people faint, we've had partners faint, we've had some anger with some swearing, you know, because, you know, and then I think, and you know, I know we have zero tolerance and all, whatever that means, but I think that how would we behave? How would I feel if I was just being told we've just told that patient? Because for the majority of patients, I mean, yes, we do cure a lot of our patients, but for the majority of patients, say the ovarian patients, those kind of patients, you know, the advanced cancers, this is life changing, isn't it? This is a death sentence that potentially we're trying to give this information and move them on so that we can, you know, and for many of them, their life is kind of going to be over quite shortly. So I think that we're responsive, things like that. Obviously, clearly, we know when we need to kind of try to take control of the situation. But I think most people do, you know, I'd like to think that most people have an idea of what's going on, and that all goes back to how they presented, isn't it? Presented at the GP and what the GP has said. They've come to A&E, they've come to 602, so gynae, you know, emergency gynae clinic, if they've been seen in clinic, and the groundwork is already done. So it's those, like you're saying, it's those kind of you know, dripping little bits of information, you know, which we try to do in a supportive manner to kind of let them know that we're worried, what we're worried about, and where we could be heading, isn't it?
Lovely. Was there anything else that anybody wanted to discuss? Any personal experience, well, patient experiences, or anything else they wanted to ask Lisa?
I just wanted to ask Lisa, with the COVID environment, like obviously with social distancing, a lot more stuff is being done virtually, or if it is face-to-face, the patients are just coming by themselves as opposed to with family, which I assume pre-COVID people would come with family members. So in terms of sort of updating their family, like do patients ask you to contact their family to discuss it, or how do you sort of go about in terms of educating everybody what's going on?
Yeah, it's a good question. So yeah, I mean, so for us in Reading, we are still doing majority of breaking bad news at face-to-face. Okay, the Sonning ward where we have one of our clinics they're very keen for, it's just the patient only, but obviously they do make exceptions, and obviously depending on the severity of the news that you are breaking. So we are allowing saying someone to bring somebody with them, you know, if we can, because we're very fortunate. We use the colposcopy suite, so we're using a very, very big room where we can all kind of be kind of socially distant. In the cancer centre, where I'm mainly at, for the first consultation, we're always suggesting somebody comes with them at that first consultation, and then for other consultations, it's kind of telephone or just patient only. But yeah, I mean, obviously as CNS, give out contact details, written information, and we do acknowledge that this isn't a normal situation currently, is it, regarding how, you know, not having your family with you, or you know, and I'm more than happy to speak to your family with your permission. And again, it's just going back to getting permission, isn't it, and saying I'm more than happy to. What I have learned is that, you know, you can have somebody with 4 children, just trying to saying, well, actually, if you've got one person in your family, you know, it can be the spokesperson if you'd like them to, then I'm more than happy to speak to them and keep them updated, and just documenting that, isn't it, really? But yeah, I think I think we all had to learn to adapt, haven't we? Kind of, you know, we know what we'd like to do and we feel more comfortable with, but yeah, I think we're doing a lot more telephone kind of consultations. I mean, some of the oncology clinics are doing video, you know, and so you know, so again, if the patient is has somebody living with them, then obviously they're part of that consultation. But yeah, I think we're just adapting, aren't we?
We are indeed. Lovely. Thank you so much, Lisa. That was very helpful.
Pleasure. Okay. Thank you ever so much. All right. Take care.
Thank you. Take care.
Bye-bye.
Then.